So I am super excited to chat with Dr. Alan Christianson. This is going to be an amazing conversation. We are going to be talking about his book, The Thyroid Reset Diet, talk about iodine, talk about thyroid antibodies. So let me go ahead and dive into Dr. Alan's bio here. So Dr. Alan Christianson is a board certified naturopathic endocrinologist focusing on thyroid care. He is a New York Times bestselling author whose recent title is The Thyroid Reset Diet. He is the product formulator for thyroid-specific formulation supplements. And Dr. Christianson has been featured in countless media appearances, including Dr. Oz, The Doctors, and The Today Show. And he is the founding president of the Endocrine Association of Naturopathic Physicians. And Dr. C, it's great to have you on the show.
Hey, Eric, happy to be with you. Thanks for having me.
Yeah, this is going to be great. I mean, I enjoyed reading your book. I forgot if I also listened to it because it's on Audible as well, audiobook version as well. And that's how I listen to a lot of books these days, but I definitely have the hard copy as well. So, yeah, just, so let's start off just talking about the book and what motivated you to write The Thyroid Reset Diet, because it's not your first thyroid related book. You do have a few other ones. So why did you decide to take the time to write this book?
Yeah, thank you for that. There have been a lot of thyroid diets proposed and talked about, and I really hadn't been that engaged in many of them because there hadn't been a lot of large clinical evidence. And then there were some recent clinical trials saying that diet could make a big difference, but it wasn't the kind of dietary approach that was commonly used. And so that was really it. I'm like, hey, this is actually pretty helpful now. We got good evidence about that, but it's not what everyone's doing. So let's take advantage of a good opportunity here.
Okay, that makes sense. And so just to make it clear for those, I mean, I know this, but for those who are listening, this was not. This is this is based on research, research, and also your experience with working with patients as well. This isn't just something like a bias where you're just anti-iodine, correct?
Well, yeah, we can talk a lot about iodine, but the whole culmination of that, it's been about 28 years of medical practice focusing on thyroid care, and with a real big bias, if anything, towards just safe, effective outcomes. I don't care what does what, where it comes from, how it works. If it's going to work and you've shown to be effective, I'm all for it. Any good, safe options. That's important to me.
So, a question I have for you: I don't know how to word this. Were you ever on the iodine bandwagon? Like where you're like, okay, like just reading. You're obviously familiar with Dr. David Brownstein's work.
Sure.
So before you did your research, were you like ever at any time like recommending separate iodine supplements, or were you always kind of on the cautious side when it came to iodine?
Well, the whole arc of that, as a physician learning medical school, learning nutrition, I was always aware about iodine being relevant with thyroid disease, but never really thought much more about it than that, kind of a thing that I learned as a historical anecdote, so to speak. And then somewhere around late 90s, I started seeing more and more patients who were developing thyroid disease after megadose iodine supplementation. This was late 90s, early 2000s. And I was curious about that. And I ended up, the origin for all of this was, dear man passed away, Guy Abrams was his name. And he wrote a group of books called the Iodine Project. They were really published in magazines called The Original Internist. And he had these articles in magazines. He compiled all that and called it the Iodine Project. That's where all this comes from. Really nice guy. I talked to him in depth, read all of his work, all of the citations. And I found it really intriguing. It'd be a really cool thing if this massive problem affecting a lot of people could be solved by just giving a nutrient. And, it was an easy thing to think that there's many examples in natural medicine to where people are getting too little of an essential nutrient. And, RDA amounts may not be enough. Foods might be low in that. It was totally an easy story for me to get into. It really made a lot of sense in a lot of ways. But the tough thing was that it was asking to suspend the last century of research on iodine. And this is probably the most studied nutrient on the planet. Many have argued that's probably the first nutrient known to be correlated with a specific disease. And we've got tons of data epidemiologically, interventionally, mechanistically. So yeah, the more I studied about the ideas behind all of this, it was plausible but it just didn't sync with what we already knew. So to answer
Yeah.
the question, yeah, I was kind of aware of that approach, but not really into it for a while until I did the research on it. And then I saw that, yeah, the mega doses were not safe. The more recent iteration was the idea that taking it below a threshold could also be therapeutic. So for quite a while, I knew that it was relevant, then I knew that people could have a problem by getting way too much. But the more recent thing that inspired the thyroid reset diet was the evidence saying that, yeah, deliberately going to a lower range short term can help fix problems as well.
Yeah. So one of the main concerns is it could be a trigger of autoimmunity, Graves, and Hashimoto's.
Yeah, fascinating thing. So iodine is unlike any other nutrient. Most other nutrients, the amount that's in the bloodstream is the amounts that the tissues get exposed to. It's the same concentration, kind of like you're swimming in soup, and what the soup has, that's what you get. That's how the tissues and glands work in most cases, but not with iodine. So it's gated. So the parts of the body that use iodine, they selectively uptake it. And it's by a mechanism called the sodium iodide symporter, or NIS for short. And the basic idea is if there's sparse amounts, you pull more in. If there's way too much, you stop it from coming in. You block it. Now, that creates what's called the iodine paradox. So if you get way too much iodine, you block the uptake of it, and you can create something that seems like an iodine deficiency. So yeah, so too much is just like too little. And if someone goes above their requirements, they can have the same problems as if they were deficient in that. It's just like if you got too much current in your house and you blow the fuse. Now your lights are out. Well, there's plenty of power there, but there's none getting in because your body shut off a safety mechanism. And it's the exact same thing for iodine and your thyroid. And a little more variation. So there's two main human genotypes. There's those who are well adapted to being in coastal environments where you'd pretty much never have no iodine or very little, and sometimes you would get a lot. So there were adaptations that allowed people to dump out high amounts, block it when needed. The other main variation was those who were adapted to being inland. So they weren't coastal. So they were adapted to being in a lower iodine environment. So they were good at operating on small amounts. But you don't get both superpowers. So the coastal people couldn't do great if they were really deficient in that. And the inland people couldn't do great if they got a lot of excess. And the problem is that the thyroid disease is primarily a genetic disease. And when we look at the genes involved in that, they're all the genes that are involved with regulating iodine. So yeah, those who are better adapted to be in lower iodine environments, if they're exposed to amounts that are not always harmful for all people, that can be problematic for them.
Okay, so you answered one of the questions, which was why can some people tolerate higher amounts of iodine, whether it's iodoral or another type of supplements. And so it's dependent on the genotype, according to what you just mentioned.
Yeah, and there's tolerate and require, and we should pull those apart. So the tolerance varies a lot per genotype. In terms of numbers, and there's been so much data on this epidemiologically. If populations stay between about 50 and 200 micrograms per day for adults, that's where you see the lowest rates of adult thyroid disease. But when you get above 200 micrograms per day, that's when those with the lower tolerance start to have problems. But those who don't really have problems, who are not intolerant, they're probably safe to occasionally get to about 1,100 micrograms per day. They can tolerate a bit more. Now, that's the tolerant side. There's also toxicology, which is not really genetically variable. And then there's requirements. So the requirements are pretty much just based upon body size. And there's really not a lot of genetic variation with that, and not a lot of differences in absorption or assimilation of it. We absorb it really well. It's quite different from like iron or B12. But yeah, the tolerance is quite variable based upon one's genetics.
And does it matter the source of iodine? Meaning if someone has that genotype, like the inland genotype, so they can't tolerate high amounts of iodine, does it make a difference if they're getting that iodine from supplementation versus sea vegetables such as kelp, for example?
That's a really good question. And I heard you say iodide. To be really precise, we could differentiate a lot of different subtypes. Most forms that we're exposed to are iodide. They're chemically already reacted with something. Iodine is formed when it's now in a highly reactive state. And that's what happens within the thyroid. We'll talk more about thyroid peroxidase. That's what oxidizes it. But in terms of what it does, there's many different compounds that can form with iodides. And that can be relevant in terms of when they're in supplements or sea vegetables. But ultimately, the biological properties are of the actual element. So once it's in a concentration to where it's freed from the bond and it becomes an active iodine, that's what does what it does. So it's a chemical element. And as such, it's irreducible. So unless you got a particle accelerator, you can't change an element. So it does what it does. And whether it's from one supplement or another, or in a nanoparticle or a raw state, where it's labeled a lot of different ways, but it's a chemical element. So yeah, that's where its properties come from. So it doesn't really differ if it's in a food source or a supplement or in a different compound or whatever.
Okay. No, thanks for explaining that. And so you're familiar with Dr. Brownstein's work, and so him and others will say, well, the problem is again the oxidative stress caused by iodine, and so if you take antioxidants such as selenium, vitamin C, other antioxidants, that'll minimize the potential risk associated with iodine. So, what
Sure,
are your
sure.
thoughts on that?
There's total truth to that, but this is a matter of degree. And so, yeah, Brownstein, Fleckus, there's a couple of people who have taken Guy Abrams' work, and they were collaborators of his. They were transparent about sharing his work. They've not innovated it. So these are the same things that Guy Abrams said many years ago. The short version of the story was that Guy Abrams was a gynecologist. He saw clinical trials showing that iodine could lower the pain from fibrocystic breast disease. And not having a nutrition background, nutrients can act kind of like drugs or like nutrients. They can do a drug-like effect, or they can fill the role of a nutrient. Iodine, for example, if I probably got a cut or scratch somewhere from working on the yard recently, if you put it on your skin, you can kill bacteria. But that doesn't mean that a skin infection is an iodine deficiency, right? So they're separate things. And the same thing is true with fibrocystic breast disease. It's not an iodine deficiency. It's more a matter, if anything, of an excess uptake of it. Well, not seeing that distinction, he thought, oh, wow, that high dose helped. That must mean they required that much. And that spawned all these same work from all these same people. But yeah, not a matter of a deficiency. So biologically, it has many properties. And yeah, someone's tolerance is largely set by their genotype, but it's also influenced by other factors like their nutritional status. If someone is lacking in selenium, that'll further narrow their iodine tolerance. That doesn't mean that one can megadose on selenium and suddenly now take thousands of times of the amount of iodine that's recommended. And it's a real problem. So anyone can go onto PubMed, and there's sad stories about many people who have been hospitalized from a thyroid storm caused by high dose iodine. There's many babies who were born with congenital hypothyroidism because the mothers were taking high dose iodine. And these were amounts and products that are recommended just verbatim by these sources that you've mentioned. So yeah, these things they're not safe. They cause big dramatic harm in some cases. And for most people with thyroid disease, getting too much can slow the thyroid and also trigger the whole autoimmune response. The slowing effect, that's the whole tripping the fuse that I mentioned. It's called the Wolff-Chaikoff effect. Now, the autoimmune response, basically, when you're forming thyroid hormones, you're first off oxidizing iodide, and that's thyroid peroxidase, and you're then attaching it onto the protein thyroglobulin. That's where iodine is stored. So iodine itself, it's a big source of free radicals. And that's why, again, we could use it as an antiseptic. So you think about like bleach or peroxide, those are things that kill stuff by making free radicals. Iodine is no different. It happens to be useful, but in very controlled amounts. So in the thyroid, when there's amounts there that are not well regulated by the body, that extra free radical damage triggers an immune response. It triggers an inflammatory response. And now the lymphocytes treat this enzyme thyroid peroxidase or this protein thyroglobulin as if they are foreign. So that's the cycle of autoimmunity. So yeah, there's so many things that can give rise to thyroid disease, but it's been argued that there's only about 4 factors that are truly causal that can do it by themselves. And that's age, gender, genetics, and iodine exposure. A recent researcher argued that of the controllable factors, that's really iodine exposure. The age, gender, and genetics are not controllable. And of the many other controllable factors that give rise to thyroid disease, it was argued that all of those together are less relevant than one's iodine exposure.
How about Graves? Because you mentioned the thyroid peroxidase, thyroglobulin. Any impact on the actual TSH receptor and kind of cause the increase in the Graves antibodies, those thyroid stimulating immunoglobulins?
Yeah, so there's less epidemiologic data about iodine exposure triggering Graves, but once it has started, then it's certainly a big driver of the disease process. All the medications targeting Graves are simply, all they're doing is delaying iodine uptake. They're simply slowing that sodium iodide symporter and making less come into the thyroid. And that's why they take about 4 to 6 weeks to do anything, because there's already a certain reservoir there within the thyroid. So the less coming in, the easier that can go. Now, the iodine paradox comes back here again. So if someone's in the emergency room from thyroid storm, the blockers like methimazole or propylthiouracil taking 4 to 6 weeks to work, they can't help in the acute portions of a thyroid storm. The only thing that can block it that dramatically is megadose iodine. And that's, again, you're blowing the fuse. So when you give a high dose of it, that's the most powerful way to shut it down. And there have been some clinical trials on using iodine as a longer-term manager for Graves' disease. The trials looked effective. The drawback is none of them were large enough so where we could say confidently that it wouldn't have raised the risk of acute thyroid storm. Because theoretically, if there is more substrate there to make hormone, there is more of a chance that the gland could go out of control. So it's possible a subset of people could have more tendencies towards thyroid storm. So yeah, you can shut it down in the case of Graves with high dose iodine. At the same time, if one is watching their iodine intake, that'll make whatever else they do for Graves treatment take much less time and require much less medication.
Okay. So it could potentially be effective, but it's just unpredictable. And some people it could actually help with if they're experiencing a thyroid storm, taking the high amounts of iodine, but then using it preventive wise, that might backfire in some cases and actually cause a thyroid storm.
Correct. That's just kind of the unknown. Yeah. Yeah, we know that during an acute storm, it's one of the most effective single treatments. But if someone were doing it chronically, they may be more apt to have a storm form. And when an acute storm happens, no treatments are perfect, and it can be life-threatening. So it's something that you wouldn't really want to risk triggering.
Yeah, definitely agree. So when someone is just focused on eating whole, healthy foods, and I mean, you go into detail in your book, and you actually list like foods like the micrograms of iodine. But I mean, how is it? Would you say it's easy to exceed the 200, 250 micrograms if you're just relying on food alone and not taking any supplemental sources of iodine? Is it something that people still have to monitor, would you say, on average?
Well, yeah. So a recent study by the American Thyroid Association addressed that question, and they were saying, what percent of the population is likely above that 200 microgram threshold? And this is the thing. You'll often hear people argue about, oh no, Americans are low or they're high. Well, their averages are deceiving. So there's a story about a statistician who had his feet in an ice bucket and his head in the oven. And he was at an average of 72 degrees, so he should have been comfortable. So yeah, so not all parts of a big thing like America are at a set number. So in this analysis, they broke people down by age, gender, ethnicity. And in all these different cohorts, the range of those that were above that safe iodine window varied from about a few of the cohorts were as low as like high 20%, some were as high as low 40%. So ballpark, about a third of the population has been known to be above that threshold by dietary intake. So it can happen. One can get there pretty easily from dietary intake. And then if there's some in supplements, that's just going to go on top of that.
And then as far as, I believe it's been a while since I read your book, but skincare products also could have iodine, and that could be a concern too.
Yeah, it used to be used quite a bit in hand sanitizers, and luckily pre-pandemic that was changed, or else that would have been even worse. But yeah, 2018, it was identified that healthcare workers were at risk from iodine-induced thyroid disease when they were using hand sanitizers that were iodine-based. That was a real common problem. Many were excreting unusually high levels of iodine. So it's a funny thing, and both thyroid hormones and iodine, they're not always intuitive because it's really about micrograms. It's about microscopic amounts of things. So iodine's a really useful ingredient in personal care products. It makes them not go rancid. It makes them stay smooth and not separate out their different constituents. So it's been in a lot of things. And it doesn't take huge amounts. The most common individual compound used is called polyvinylpyridone, or PVP. Now, a lot of natural products can use that and call it a kelp extract or a sea vegetable extract. The same thing. It's just a useful stabilizer. And it doesn't take a lot. It might be just a few percent of the product that contains PVP. And then PVP is about 12% iodine. So it sounds like we're not talking about very much, but again, it's micrograms. So if you take like a conditioner, for example, and you do a couple pumps of that, you got about 20 grams or about 20 million micrograms. So now you take down that 1%, and now you go at 12%. Then you figure that intact skin might absorb about 4% with a couple minutes of exposure. And what you're left with is still about 1,200 to 2,000 micrograms that could be entering the bloodstream. So that can be another source for people.
Very interesting. Definitely want to talk more about thyroid antibodies, but before we move on, anything else you'd like to chat about related to iodine?
Well, one thing that creates a lot of confusion is iodine testing. A lot of people will say, or many will hear different views, and a super logical approach is, well, let me just test my patients, or let me just get myself tested and see where I fit in this. The drawback is that iodine is really volatile, and it's really the amount in the thyroid and how your immune system responds to it that matters the most. It's not just how much is in your blood or in your urine. The urine does reflect your overall intake, but not on a 24-hour cycle. So if you're studying populations, urine tests are fine for nutritional status if you're looking at groups of 500 or more people. But when you're looking at individuals, they've done a lot of math on this. You have to test someone literally over 200 times to be within even 80% confidence of their status. One test tells you pretty much zero, just because there's so much variability. And that's even for a 24-hour urine or a spot urine or a challenge urine. So it's simply not a meaningful thing. Serum tests, blood tests are used quite a bit too. What they exist for is for evaluating the effects of iodine in toxicology ranges. Almost the main reason for this, there's a medication called amiodarone, which contains a lot of iodine, like 250 milligrams. Now we're talking thousands of micrograms per tablet. And this medicine can have side effects that anywhere in your body, and they might come on 6 months after usage. So the useful thing about a serum test is basically someone who's had amiodarone, they're having something like kidney failure, and you're wondering if they've still got too much iodine. So you test their serum. So the serum levels only elevate when the kidneys can't clear it anymore. Before then, they might be higher or lower, but there's no correlation with the nutritional status of iodine. So yeah, many people get urine tests or blood tests, and from there they think, oh, I was actually low or I was high. It really means nothing. And then the most meaningless is the skin test. So you can smear it on your skin and it'll disappear after a while. Well, the story is that it disappears faster if your body wants it. And the kernel of truth is that there are some nutrients that our intestinal tracts absorb more quickly if we're lower in them, like iron, for example. And the other kernel of truth is that a lot of things do get in our bloodstream from our skin. But our skin can't pick and choose. Our skin has no way of preferentially absorbing based upon our requirements. And then the other big disconnect is iodine disappearing doesn't correlate with it absorbing. It correlates with it oxidizing by interacting with oxygen. So yeah, so iodides are dark, iodine is invisible. So that one doesn't mean anything either.
Okay, good to know. So really no great test for iodine, whether it's a urine test, serum testing.
Well, testing, not so much. You can get a good sense of your status just by knowing your intake. Made iodine inventory. You can just know what's in your medications, your thyroid meds, what's in your supplements, what are the main food categories you consume. And because iodine is pretty consistently absorbed, you can know your status based upon what your intake is.
Yeah, and definitely for more information, highly recommend Dr. Allen's book, The Thyroid Reset Diet. So check that out. And yeah, let's talk about thyroid antibodies, because there also is a lot of controversy with thyroid antibodies as far as if they're too high, does that at all relate to the severity of the condition? If is it possible to have false negative antibodies, which I know the answer to that, but some people don't know the answer to that. So if you could talk a little bit about what people should look for with the thyroid antibodies, are the concerns if their thyroid antibodies are crazy high compared to mildly high?
Yeah, great question. And this is a fascinating thing too, where you've done a lot of good work on Graves' disease. And the funny thing is that there's discussions now in the medical literature about Graves and Hashimoto's being one disease, with a continuum of how it manifests. So there's a lot of overlap between the autoimmunity in both of those diseases. And as a generalization, this is something that just makes me nuts. So many conventional doctors just do not wish to test or entertain the relevance of thyroid antibodies. Now, to their point, the antibodies aren't big predictors of thyroid disease, actually. They really don't have that strong of an effect upon predicting who will develop other versions of thyroid disease. So that's why they dismiss it. But the drawback is the antibodies have big effects upon health and symptoms and disease risks independent of thyroid function. So no matter how perfect your thyroid is working, if you've got marked autoimmunity going on, that by itself can cause a great deal of problems. So that's where they should be taken into account and screened and looked for. Now, to credit the conventional side again, they don't really have a lot of treatment options for them that they consider useful. You can give high-dose steroids like prednisone. You could surgically remove the thyroid. You could do immunosuppressants. But really none of those things, that's killing flies with a shotgun. None of those things, the harmful effects would outweigh the benefits. But yet there is good evidence that diet, lifestyle, nutraceuticals can be helpful for the antibodies.
All right. So you said that just because someone has, let's say, thyroid peroxidase and or thyroid globulin antibodies, that doesn't necessarily mean that they will develop thyroid disease, that eventually they will develop hypothyroidism.
Let's put some numbers on that, because our language really lacks the nuance of predictive value. You could say, is it a risk? Is it not a risk? It is a risk, but here's the numbers. So one of the recent studies looked at people that their 9-year risk of developing overt hypothyroidism, having their thyroid actually shut down. And they were broken down into those that had really no measurable antibodies, moderate elevations, and high elevations. Now, this cohort had about a 1% annualized risk for developing thyroid disease. We see that in most populations, and that's when they had negative thyroid antibodies. Now, with the highest level, where both antibodies were what was considered the highest elevation per this study, the risk was higher. But if you annualize the risk, it went from 1% to about 1.7%. So it was higher, but in the big scheme of things, so you could say, well, it was almost twice as likely. Well, it was, but it was 1.7%. So for someone to be told, or for a doctor to think, oh, wow, your antibodies are high, your thyroid's about to shut down. Well, there's a 98.3% chance it won't.
Yeah, that's really high. So, and you talk about long term, not even just like over the next 6 to 12 months, like
so you take it over 9 years, you're talking about like an 11 to 13% risk. Yeah, so like 10% risk over 9 years roughly.
So and the thing is that I guess the challenge is they don't test it, or I don't know if you maybe not consider it a challenge, but they don't test antibodies typically unless if the TSH is out of range and maybe the thyroid hormone. Some will just look at the TSH,
well,
but
it doesn't change treatment regardless. There's a few cases of what's categorized as subclinical hypothyroidism, where some guidelines will take into account marked antibody elevations. But in most cases, yeah, it doesn't really inform or influence conventional treatment.
Yeah. Well, my point is that in most cases, you wouldn't know if you had thyroid antibodies in the absence of thyroid disease, because you're usually not testing the thyroid antibodies unless you have thyroid disease. Mm-hmm. But if you were to do the opposite, and let's do predictive antibody testing and test the TPO and or thyroid globulin antibodies, maybe even the TSI in the absence of thyroid eye disease, like I'm sorry, in thyroid disease, I guess, is there any purpose then of doing that if most people aren't going to develop thyroid disease to begin with? Like, if,
well,
or
the question,
let me just say that
they're clinically relevant, if they're relevant in any other way. Yeah. And that there's so much evidence on this. So normal thyroid function, elevated antibodies, has been clearly shown to be correlate with poorer quality of life symptoms, hair loss, anxiety, fatigue symptoms. And we look at health risks. There's clear data about cardiovascular disease, infertility, certain types of cancers, autism, born to children whose mothers or antibodies are up. And these are all with perfect thyroid function. So yes, high antibodies, even in the absence of thyroid abnormalities, they're very clinically relevant. For many
Yeah.
people, they're a source of ongoing symptoms.
Okay. And then, yeah, I think you just mentioned also like genetics too in there too. Like if there's a family history, a mother has Hashimoto's, maybe it's also not a bad idea to eventually test her children for antibodies, even if the thyroid is seemingly normal, just because greater likelihood of developing those autoantibodies.
Well, certainly if they have any thyroid suspicious symptoms, and yeah, just knowing a family history, that can justify one taking steps to minimize the risk of developing thyroid disease. Keeping iodine reasonable, making sure that selenium and iron statuses are healthy. There's actually just a new paper that came out today from the NIH, from one of the NHANE studies, showing there's a pretty strong inverse correlation in many populations between serum iron and Hashimoto's onset. So yes, so many nutrients are important, and the more one can do to cut the risk of things that go wrong that trigger thyroid disease, that's worth doing, especially when there's a family history.
Agreed. So getting back to negative antibodies,
Oh
if
yeah, great.
someone has, yeah, if someone has Hashimoto's in the presence of negative antibodies, or I guess Graves in the presence of negative antibodies, is there a way to determine that they still have Hashimoto's or Graves, like via an ultrasounds or other types of imaging? Or
You're exactly right. You're talking about what's called seronegative Hashimoto's, or seronegative Graves. Hashimoto's, first off, we know about the numbers mostly from studies that looked at people after they had thyroid biopsies. So they had a biopsy done for some other reason. The biopsy is the most definitive way to confirm or rule out Hashimoto's. And then they would take those that were known to have Hashimoto's on biopsy and look backward and see, did they have measurable thyroid antibodies? And yeah, so biopsy proven Hashimoto's, roughly half the time, the antibodies are negative. And that's even those that had it for a larger length of time. So yeah, so seronegative Hashimoto's is a well-known phenomena. Now, if it's suspected, a biopsy is really not a practical step for that, but ultrasounds can be. And that can be one way that you can often see the telltale signs of autoimmunity by the specific changes that occur on ultrasound. Now, the same thing happens for Graves. It's a little more rare, and it's also more time dependent. So the first year someone is manifesting hyperthyroidism that's suspected of being Graves, there's about a 5 or 10% chance risk of being seronegative. So in most cases, the receptor antibodies or the stimulating immunoglobulins are going to be positive when Graves is there. And then if you go out after that first year, it's probably 5% or fewer that are seronegative. So it does happen that there's false seronegativity with Graves. It's just more rare than with Hashimoto's. And in those cases, yes, ultrasound, iodine uptake, those are the main ways you would know about that in a seronegative case.
and do you know the reason why those cases are seronegative? I know they're IgG based, so I don't know if like it makes sense test the immunoglobulin G and see if that's depressed or if there are other mechanisms involved.
Well, we're going to get pretty weird here, but the answer to that in clinical research is that the antibodies we're aware of are probably not the actual causes of thyroid disease. They're smoke that's often present with the fire, but not always. So you can have really hot coals that could burn you. I remember my grandpa, we had a barbecue and he buried the coals in the sand somewhere. I didn't know. I was walking around barefoot, I burned myself. Well, there was no smoke, but they were pretty darn hot. So that's the same way with the whole autoimmune process. We know of about a dozen different immune mediators that are probably relevant for that occurring. Most of those really can't test for clinically. So yeah, so the antibodies are kind of like smoke. Generally, you got a hot fire, you got some smoke there as well. Not 100% of the time though, because it's not the smoke that's doing the damage.
Yeah, so it's more of a consequence of the autoimmunity, not necessarily the cause of the autoimmunity, those antibodies.
Yeah, it's often there present when it's going on, but just not always.
Yeah. How about with Graves though? Because I mean, I agree. It seems that thyroid peroxidase and thyroid globulin antibodies, they're not actually doing any damage, whereas the thyroid stimulating immunoglobulins not necessarily doing damage, but it seems like, at least according to the research, that they're actually binding to or stimulating the TSH receptor.
Oh, for sure. So yeah, in mechanism of action of hyperthyroidism, it's probably a big driver. But yeah, not triggering tissue damage. My favorite analogy there is just like a short circuit on a doorbell. When it works right, the doorbell goes off, somebody's there, you open the door. In the case of Graves, you're triggering that response, but there's nobody there. And the thyroid thinks it's being told to work, but it's not. And it's kind of a funny quirk of language and acronyms that we have TSH, the thyroid stimulating hormone, and then TSI that are almost the same thing. Your thyroid can't really tell those apart either. So your thyroid's listening for TSH, waiting when it should be told to work, but it can't differentiate that from TSI. So the errant immune cells can set off the doorbell, even though there's no one there.
Yeah. Okay. And then another question. So, yeah, find this fascinating, this conversation. So seronegative antibodies for someone with Hashimoto's or Graves', how would they be able to tell if they're in remission since the antibodies are negative? Are there other ways, or I don't know your approach? Do you consider ever someone to be in remission? I mean, you practice functional medicine, so you're not just giving thyroid hormone replacement for those with Hashimoto's or antithyroid meds with those with Graves'. So what other factors do you look at before you determine someone might be in a state of remission?
It's a funny thing. In a lot of the pop health space, so to speak, people put a lot of weight in the idea of being in remission. It's not really a defined term. People can mean that they no longer need medication. Some say that means their antibodies are negative. There's really no strict definition for that in medical literature. So yeah, many people who were given thyroid medications, we could talk a lot about this one. This is a big soapbox of mine. Most of them were prescribed them unnecessarily and never needed them. And many can withdraw and taper and come off very successfully. So that's remission of hypothyroidism. Now, the other paradox about thyroid antibodies is that they're also natural mechanisms, back to primarily thyroid peroxidase and thyroid globulin. They're natural mechanisms of killing old cells. So some people have them positive to a low amount, and they're really not relevant. They're not always causing a problem. So yeah, so some are concerned about antibodies and levels that are not clinically relevant, and they consider remission when they're negative. The other paradox to throw into account is that if your immune system is suppressed or weakened, almost all things that are measured that are antibody-based become negative. So you could ruin your health in a lot of ways and have antibodies become negative. Same thing for allergy testing. You could take immunosuppressant medications and now all your allergy tests are negative. You're not healthier. Yeah. So negative antibodies, as a generalization, when they're extremely high, that's usually a problem, and lower is better. But there are many people who fixate on those things being to zero, or they're being super bad if they're even up to a tiny amount. That's not always true.
Yeah. Okay. Yeah. Thanks for explaining. And so you said there's no definition of remission. That being said, at least your definition, like can someone with Hashimoto's still be considered to be in remission if they're on thyroid hormone replacements? I mean, if they're feeling good, let's say their antibodies are negative and they're true negative antibodies, but the damage is just severe where they, at least at the time being, can't get off the thyroid hormone replacement?
Well, so the antibodies have very little correlation with the requirement for thyroid medications. So the only thing that correlates with that is overt hypothyroidism, where the glands really shut down, or being athyrotic, not having a thyroid. But there's not a strong correlation between antibody levels and thyroid hormone output. So yeah, there's some rare variants of Hashimoto's that are different, like Orr's disease, but the most common types, there's just not a strong relationship there. Now, being in remission, as far as, let's say, even like take the word out because people have different meanings about it. Let's just talk about getting better. So can someone get better? Can they decrease antibodies and correlated symptoms and problems by safe, natural methods? Most can. There's good evidence about that. So one of the clinical trials that inspired the thyroid reset diet took people that had marked elevations of antibodies and overt hypothyroidism. So TSH scores averaging 14 to 200, quite high. 3 months of just one simple dietary intervention, 78% had normal thyroid function with no medication. So yeah, those who are not on medication, a good chunk can get better. Those who are on medication, there's been a lot of focus now on people who have been unnecessarily prescribed thyroid medication. And most of the recent studies have also encouraged iodine reduction as part of the process to help them come off. Thyroid meds contain a lot of iodine. And so if you're consuming an adequate amount already between diet and supplements, and the meds are on top of that, that makes one more barrier for your thyroid to function normally again. So if someone is more deliberate about being lower on iodine to allow room for what's in the medication, they get better odds of no longer needing the medication. And yeah, studies have shown that about 84% of people can decrease their medication and be stable, and about half can come off. And there's a lot of different cohorts that go into those numbers, but yeah, most on medications or prescribed unnecessarily, and most can reduce or come off.
That's great news, just by reducing their iodine intake.
Well, there's a process of tapering. Some people, if they do that alone, their medicines will suddenly become outgrown. They'll move to a hyperthyroid state. And they stay on the same dose, but now their TSH goes below range. That's a clear sign their thyroid's coming back online again. For many, that doesn't happen, but if they were to taper at a safe prescribed process and be supervised for that, they could be tracked over time and stay stable. So yeah, so some just see that they need to reduce, others then now have the potential to reduce.
And could this be true even if someone's been on thyroid hormone replacement for quite a long time, like 10, 15 years?
You know, the stats change. The odds are highest for those who've been on it for 4 years or fewer. But currently, I've seen people now 45 years on medication that now are on none and doing fine. So it's not impossible. For someone who has a thyroid, it's not impossible. And it doesn't work for everyone, but for many people, it can.
Okay, no, that's great. And you mentioned iodine. I'm sorry, you mentioned thyroid hormone replacement is high in iodine. Is that both levothyroxine as well as desiccated thyroid?
A little more so for desiccated thyroid, actually. So the active hormone, the T4 and the T3, the 3 and the 4 refer to atoms of iodine. Levothyroxine, if you look at the dosage per active ingredient, it's like 100 microgram dose of levothyroxine, it's about 65% iodine, it's about 65 micrograms. Now, the dose equivalency of desiccated thyroid, it's really hard to make dose equivalencies, but the best comparison is probably about 60 milligrams. Now, the difference here is that a lot of the iodine in desiccated thyroid is not in the active hormone. It's in other iodinated proteins. So per a 60 milligram dose of desiccated thyroid, it's about 0.02% iodine. So you run the math and you get about 130 micrograms of iodine per tablet. In the big scheme of things, if someone needs thyroid meds, I would not encourage them to choose their medicines based on the iodine content. There's a lot of folks who need meds who can do better on desiccated thyroid. But when someone is tapering or deprescribing, it's just one more thing to take into account.
All right, very cool. Thanks for explaining that. Do you have a preference when it comes to levothyroxine or desiccated thyroid, or it just depends on the person?
Well, there are populations to where desiccated is not a great option. You know, pregnancy, lactating, elderly, kind of a deficit of data. We're not totally clear about that as much. But in populations where it is an option, there are many that find it preferential, and many that feel better on it, even at the same levels. And yeah, and there's also many that do fine on T4. Most people that I see who are on thyroid meds and not doing well, it's often not even a matter of which medicine is do they need medicine? Do they need it in the first place? Because if you don't, what happens is when you take it, your body loses a whole lot of homeostasis. We can measure the tiniest bit of thyroid homeostasis between the things we have access to in our blood tests. There's another dozen levels behind the scenes we know of that we can't measure. And there's unknown unknowns as well. So yeah, we lose a lot of homeostasis when we take over a big, important job by our bodies. And many people are symptomatic, even with optimal perfect blood levels. Those same people do fine when they're now taking care of it on their own again, and they're not taking external therapy when it's not necessary.
So for someone who, let's say they were just getting a random physical, TSH was detected to be was elevated, and then the endocrine, or I guess in this case, maybe the medical doctor, because they were just getting a physical, medical doctor puts the person on thyroid hormone replacement just because the TSH was elevated.
No.
And especially if that person wasn't experiencing hypothyroid symptoms, they just had the TSH elevated. So it sounds like there's a good chance, again, we can't give specific recommendations here, but just saying that if maybe they read the thyroid reset diet, minimize their iodine intake, and incorporate other diet and lifestyle factors, that they might very well be able to reduce or even get off the thyroid hormone replacement.
So what you described is what we call subclinical hypothyroidism. And there have been massive articles in the last couple of years in the Journal of the American Medical Association and in the British Medical Journal asking the question that you asked. Is someone like that, are they better off taking medication for their TSH being elevated? There's movement now afoot to relabel that as a laboratory artifact and not with a name that sounds like a disease. Subclinical hypothyroidism is not hypothyroidism. The thyroid is still functioning just fine. There is this TSH elevation, and some people are certainly possessing thyroid symptoms, but not that many more than are present in the population with normal thyroid function. And the data is totally clear that at a population level, when the only variable is thyroid medication, there's no net benefit to symptoms and there's no net benefit to health. And there's a lot of risks that are created. There's about 15 types of cancers that people are put at risk for when they're unnecessarily put on thyroid medication. That's based on 5 pretty big global studies now in the last many years. So it's a huge decision. And yeah, there's really no net benefit. Now, the difficulty is that when someone is seeing a person in natural medicine or functional medicine, the only variable is not medication. They're doing a lot of other things. And if they are doing better, it's probably more credit to those other things than it is just to the medication.
So you said, just backtracking, you said that taking thyroid hormone replacement can increase the person's risk of developing, did you say 5 different types of cancer?
No, 15.
15. Okay, 15.
15.
Okay,
You
even
just
worse.
counted it a couple days ago. I was saying 12 and someone asked me which 12. So I made a post with them like, oh no, it's 15. I had to recount.
And that's, I don't know if this research showed that it's actually like, because correlation doesn't always mean causation. So they're pretty sure it's due to the actual like levothyroxine, for example.
Well, so thyroid hormones have a lot of effects that induce tissue turnover and induce cell activity. And that's not different than any other hormones that are implicated with cancer risks. In fact, even more so than many others. This is true for T4 and T3. So there's mechanistic evidence supporting this possible correlation. You're right, correlations don't prove causations. This is how we learned about tobacco, as populations have higher risks. But the studies looked at cohort populations that are not on thyroid meds, and they did a pretty maniacally accurate job of lining up the other risks that were present. And same number of smokers, same number of obese, whatever else. And here's a cohort that's just like that, but they're on thyroid meds. And it's pretty compelling because, again, there's 5 different studies, and each of these studies was done in different parts of the world. They were independent, and they saw the exact same cancers at pretty much the exact same degrees of risk. So it's a compelling concern. And the thing about our risk is that it's not definite. No one's saying this definitely will happen or this definitely is a problem, but it's a risk. And people should be informed of risks when they're present.
Yeah, I agree. It just makes me wonder because most people are on thyroid hormone replacement or on levothyroxine, many of those people on Synthroid, which also has other ingredients, fillers and other things. So it just makes me wonder, is it the thyroid hormone, the actual thyroid hormone replacements, or is it the fillers and the levothyroxine? Again, we don't have an answer to that right now. But
there's not really good mechanistic arguments for the fillers and the doses used, but there are pretty clear mechanistic arguments why T4 and T3, and probably even more so T3, can be a driver for those cancers. They're known to do that in cell studies in vivo. And we know that we take away a certain amount of internal homeostasis when they're given exogenously. So it's a compelling concern.
All right. Well, very interesting. And before we wrap things up, is there anything else that I should have asked you that I didn't ask you? Anything else you want to chat about related to iodine, thyroid antibodies, or anything else?
Oh, you asked great questions. You're super knowledgeable about this stuff. I'm happy to be able to just have a chance to speak with you about that. I guess the big thing I just love people to hear is that, I encourage them to keep listening to what you're sharing with them and not to give up on their hope, but to realize that, my experience from doing this now just about 30 years, more than ever before, I'm hopeful about the capacity for the body to work by itself and for the hypothyroid to heal and for the power of simple changes in diet, lifestyle, nutraceuticals. These things are big. So yeah, if you learn the sort of things you'll learn about here with Dr. Eric and you apply those and you work with good doctors, don't give up on feeling your best and don't give up on your body working well again.
Well said. Well, thank you so much, Dr. C. And where can people buy your book, The Thyroid Reset Diet? Where else can they find out more about you?
Wherever you buy books, your local bookstore or Amazon, or the books are all there, audio form as well. And drchristianson.com. No wrong way to spell it, just drchristianson.com. And that's my main hub for blogs and updates and articles.
Okay, wonderful. Of course, make sure to put the links in the show notes. And again, this was an amazing conversation. Thank you so much, Dr. Allen. It was great chatting with you.
Good to be with you, Dr. Eric.